I have no conflict of interest to disclose here, but I am affiliated with a number of organizations that Stephanie has previously mentioned. And in addition to Stephanie's land acknowledgement, whenever I present, I always make sure that I do a land acknowledgement to acknowledge the original custodians of this land and pay my respect to the elders, past, present, and future, for they hold the memories, the traditions, the culture, and the hopes of Indigenous people. And I'm personally grateful for relationships with all Indigenous and Métis people who have a history in this territory. Today, I'm speaking to you from Thunder Bay. And it's really my understandings of the teachings around land acknowledgement and from Indigenous cultures that it's really important to begin in this way to ensure that we're able to work together in a good way today. So I hope that we're able to do that. I would like to also acknowledge my esteemed co-authors. So Nico, Laura, and Daniel, let me tell you a little bit about them. They wrote this article with me. Dr. Norquier is an assistant professor, critical care and respiratory therapy, and a clinical ethicist in the section of integrated ethics in cancer care at the University of Texas MD Anderson Cancer Center in Houston. He's also a research affiliate of the Center for Healthcare Ethics, and he's a professor extraordinaire of the Department of Dietetics and Nutrition at the University of the Western Cape in South Africa. Dr. Webster, she is the director of their bioethics program at Virginia Mason Medical Center in Seattle, Washington. She is an affiliate faculty member of the Department of Bioethics and Humanities at the School of Medicine at the University of Washington in Seattle. So she's a nurse and a bioethicist with a PhD in bioethics. And last but not least, my colleague, Dr. Daniel Garros. He's a clinical professor in the Department of Pediatrics at the Faculty of Medicine and Dentistry at the University of Alberta. And he's also a member of the Ethics Committee, and he's a senior attending physician in the Pediatric Intensive Care Unit at Stollery Children's Hospital, Edmonton, Alberta. So I want to share with you a little bit how this article came to be and how I met these wonderful co-authors. So I was actually talking with my colleague, Nico. We worked together on a number of projects previously, and we were talking about the stories that were coming into the news about family members not being able to be with patients, sometimes at end of life, sometimes at different points in illness trajectories. And he said, you know, it's funny that you're talking about this. I was just reading an article by this Dr. Laura Webster. And I said, well, I was just reading an email chain that this Dr. Daniel Garros was part of. And neither one of us knew the other individuals. And so he said, how about I'll reach out to Laura, you reach out to Daniel, and let's see if we can start a conversation. And that's what we did. And within that same day, we had responses to our emails, and we started having Zoom meetings, talking about these issues across provinces and across borders. And this article was about 1 year in the making, us having conversations with each other, doing in-depth literature reviews. Nico had a wonderful librarian who helped us out with that. And then we started contacting academic publishers. And would you believe we got turned down time and time again? Nobody wants to hear about this during COVID. You know, there's much more important COVID articles that need to be published and that were being privileged at the time. But we were very lucky to connect with the Critical Care Journal that we've now published in, because not only were they interested in this topic, they were willing to publish in open access, which means that it could be made available to a much wider audience. So we're very happy with that. And we feel like our article came out really at the tipping point. And now you see a lot of articles on this topic. So a lot of resources for you to draw on if you're interested. So for today's talk, really, we're going to talk a little bit about some of the challenges that we saw during the pandemic and really that are still ongoing in some circumstances. More importantly, we're going to talk about the impacts of those challenges and how those impacts have affected various stakeholders. We're going to talk about some opportunities to make positive changes. And many of you may or have already seen positive changes happening at your organizations, which I think is really important. And for my own work, I think it's really important to take a strengths-based perspective and say, you know, these are the lessons that we learned the hard way. What can we do about it for future? And lastly, I'd like to share with you some evidence-based rationale that you can use to support some discussions around this topic, and also some resources that you might look at. So I'm going to begin with really a basic definition of family-centered care. You probably have some thoughts in your mind about what it is. I'm going to be using the Alberta Health Services definition. I think they talk about it quite nicely. They say that patient and family-centered care means that patients and families are full partners in care, and this needs to happen in a supportive and respectful environment, not only for the patients and families, but also for providers, with the purpose of and intent of promoting wellness and teamwork. All really great and important ideas. That it also needs to happen within a community of mutual respect. And how does it happen? Well, it happens with supportive relationships. That not only includes the stakeholders that I've just mentioned, but it may also include working with businesses, organizations, and associations that may be able to contribute to the well-being of patients, families, healthcare providers, and the community itself. So really big concept when we think about what we're committing to when we say family-centered care. And I like to bring it back to this idea of who is family. So I can remember back to when I was a nursing student and my nursing professor saying to me, family is defined by the way that a person describes it. So very much like our nursing definition of pain, pain is what the patient says it is. Family is who the patient says their family is. So we know there's going to be a lot of diverse variations of what family looks like. And alongside that, we also know that the meaning of family is going to be quite variable. But we also need to remember that the meaning of family can be potentially invaluable, and something that as healthcare providers alone or as a healthcare organization alone, we could likely never provide, never even come close to providing. So we need to be really mindful about what family-centered care means and what we're committing to when as an organization or as a team, we say that we believe in family-centered care. And thinking about some of the pandemic-related restrictions on visitors, who's considered a visitor, how are we going to define that, what that looks like if we restrict visitation across the lifespan, and also what it looks like in different healthcare sectors. So I'd like to unpack that just a little bit, and you may even have your own examples. They might be personal, professional, maybe things that you've read about in the media. So we heard conversations about essential and non-essential care partners. A lot of this language came out of long-term care, and hard to really put a strict definition on that in terms of who is essential, who is non-essential, what does that relationship look like? We also saw during the pandemic regulations around a limited number of visitors, perhaps per day, sometimes per the entire stay that the patient was in a healthcare organization. We also saw time limits, 5 minutes at the bedside, 20 minutes at the bedside. We're starting to think about how some of these policies and procedures were put into play and what was the rationale behind some of these limitations. There were many instances where absolutely no visitors were allowed. And of course, there were some end-of-life exceptions. Many very sad stories about people moving very quickly into that end-of-life space and family not having those visitor restrictions lifted in time for people to be there and say those final goodbyes. We saw rules and regulations around high-risk patients, so certainly COVID positive patients, and also high-risk procedures. So aerosolized procedures were definitely part of policy and protocol. And we also saw situations where there were absolutely no exceptions, and healthcare providers and family members turned to the media to talk about patients dying alone. And we're going to talk about some of the impacts of that happening. We saw healthcare providers sometimes quietly, sometimes a little bit more boldly, talking about bending and breaking the rules to try to uphold their ethical values and their fiduciary duties to patients and family members. So I can remember one story of a nurse talking about putting her cell phone in a Ziploc bag and trying to do a FaceTime session for a family member and a patient, kind of at the 11th hour, knowing that that definitely wasn't part of the organization's protocol. And so we see experiences of moral distress, moral injury in places where moral hazard is occurring. And I'll unpack those terms a little bit in a moment for you if you're not familiar with them now. And we really saw an over-reliance on triage algorithms during the pandemic. That, if this is happening, then this is the next thing that we do. And really wasn't a lot of evidence-based rationale backing up some of those triage algorithms. And one of the things with the algorithms that we need to think about is that what information is being privileged or prioritized and what information is being left out. And so this question of unjustified restrictions and what makes the restrictions justified. It can't be that we're just in a pandemic because we know that there were many phases and stages of the pandemic. And so we needed to have restrictions that were responsive to the particular phases or stages of the pandemic that we were in. So when you think about pandemic-related restrictions, I want you to not only think about what you know right now, but I want you to take a moment to think about your own loved ones, your own family members, various ages of family members across your local and your extended family, perhaps. I want you to even think about yourself as a patient during the height of the pandemic and what your wishes and wants might have been. I want you to consider situations across the lifespan. So babies, children, situations where the protocols dictated only one parent allowed. How were parents going to choose that? Only one designated caregiver per day. Parents needing to choose to attend a high-risk procedure that may result in death, perhaps an extubation of an infant. Whether or not a parent could be there and which caregiver would be able to be there. So situations in neonatal intensive care and pediatric intensive care units. I want you to think about youth and young adults, perhaps with mental health issues. I want you to think about partners, husbands, wives unable to visit. I want you to think about situations on obstetrical units, the birth of a new baby, a father or a partner wondering, will I be able to be present for the birth? A pregnant mom wondering, who will be there to support me? Will I know that person at my side? I want you to think about adult children who want to be there for their aging parents, older adults with dementia, perhaps in long-term care or complex continuing care settings. And what about the centenarian, that older adult who was basically healthy? They fell and they broke their hip, they were hospitalized, surgery was delayed, all due to the pandemic. They weren't end of life, so they didn't qualify for those visitor restriction exemptions. And then, although they were not COVID positive, family were not able to visit them. And after only a few days, they passed away alone. We also recognize that end of life and moments where death may be upon us can be extremely hard to predict. These are the situations that we've lived throughout the pandemic. So challenges, we recognize that organizations didn't put these policies into place to cause all of this hardship. They put them into place for very good reasons. But one of the things that we try to address in this article is that one size fits all in terms of policies and protocols really doesn't fit anyone very well. So we've already talked a little bit about different patient populations and different needs. We talked about across the lifespan, acute and chronic care needs perhaps, but we also have to recognize other factors. We saw varied prevalence of COVID-19 across regions, provinces, and countries. So if organizations or communities were going to adapt or adopt practices from other places, they may not have taken that context into consideration, or they may have left a particular protocol in place long after prevalence had changed. We also saw varied specificity and sensitivity of COVID-19 testing. especially here in Northwestern Ontario, we had a real lack of availability testing. And we also had varied time for results to come back. So in the early days, we saw sometimes it taking a number of weeks, certainly a number of days, all the way down to a number of hours. Now we're seeing minutes for the availability of test results. These were all major factors in the policies and protocols that were put into place. And of course, last but not least, these are in no particular order, we saw some very significant and real concerns related to scarcity of resources and concerns about resource allocation. And certainly in Northwestern Ontario, we were already under-resourced in a number of areas. So this only added to the pressure cooker that was experienced. And when you think about resources, we also have to consider the wider range of resources that were being looked at. So not only critical care beds and ventilators, sometimes medications were an issue, certainly personal protective equipment, and also the healthcare providers themselves, especially those with specialized training for critical care settings. So we saw some very much real and also perceived barriers. We saw a lot of fear, and we saw organizations that, rightly or wrongly, were quite risk adverse. And on top of all of this, we saw situations where maybe there wasn't a lot of time to make some of these decisions, to quickly respond to a situation at hand. And we also saw individuals who were perhaps best placed to have input into these policies being very busy at the bedside and not able to have that input and participate as much as perhaps we would have liked them to. And so where are the impacts? So a number of stakeholders to consider. We always consider patients and families. Sometimes I think healthcare providers get forgotten within the mix. And so their experiences of visitor restriction are really a focus of some of the articles that we see coming out now. And I think that's a really important component. And the articles that are coming out now really speak to things like moral distress, moral injury, and moral hazard. Now, these have been an issue in healthcare for many decades, but COVID-19 has really provided kind of the straw that's broken the camel's back, where healthcare organizations and systems can no longer not pay attention to and address these experiences. So let me unpack these a little bit before we move forward. Moral distress is an experience of an individual when you feel forced to go against your conscience. It arises when a person feels compelled, either by a system or a circumstance, to do something, participate in something that they believe is morally wrong. And it can have lasting effects. The literature refers to this as a moral residue, and it can have a devastating impact on healthcare providers, especially over time, and if it's not being resolved and addressed. Moral injury is a term that was first coined within the military, very much referred to soldiers' experiences of war, but we're writing about it in healthcare now. And so you'll find many instances where healthcare providers, physicians, and nurses are talking about moral injury as a condition of some types of moral distress. And moral injury relates to being unable to do what one determines is just and right. And it can involve really intense feelings of betrayal, shame, guilt, anger, and a sense of loss of your moral integrity. So this is on a really deep level. It involves the loss of your existential belief that the world is a good and a safe place. So you can imagine the incredible impacts of moral injury. And lastly, you want to unpack the term moral hazard. So moral hazard occurs when decision makers are not the ones who have to live out and suffer the burdens of the decisions that are made. So moral hazard occurs in a situation where exactly what we're describing here, visitation is being restricted, and those who are living out the implications of that decision are really struggling. So it really refers to the fact that when others bear the cost of the outcome, a place of moral hazard exists. And so in this context, we're talking about healthcare organizations as places of moral hazard, or at least the potential to be places of moral hazard. And so what do we see in terms of the impacts? So certainly for healthcare providers, very high stress levels. They already had high stress levels, so adding to that, we see compassion fatigue, burnout, frustration, anger, numbness, physical symptoms, and emotional and mental health symptoms as well. And we're seeing this play out as healthcare providers are leaving organizations, leaving their professions. And perhaps if you're here today and you wanted to hear about this topic, your knowledge of some of the impacts was the reason that brought you to want to hear what I would have to say today. In terms of impacts on other stakeholders, so we look at the effects on patients and families. So not only the immediate effects of not being able to be with a loved one or dying alone, we also see patients and families perhaps avoiding healthcare because they're afraid that they will be alone, that they will be isolated, that they will be unsupported. So we've seen throughout the pandemic that patients are actually sicker and more critically ill when they do present to the ER or to their family doctor or the NP clinic. We also see, as a result of moral distress and moral injury and that environment of moral hazard, healthcare providers leaving healthcare. So we look at this from a perspective of recruitment and retention issues. This is the language that healthcare systems and organizations pay attention to. We're seeing early retirements of very seasoned nurses that we can't afford to lose. We can see overall low staff morale and issues of absenteeism and presenteeism. So many impacts at many different levels affecting many stakeholders. Now to the strengths-based component, where do we have opportunities to have responsive protocols? If you're in an organization that is already doing this, how can you acknowledge that and make sure that your staff knows it, patients and families know that your organization has, done the work to provide responsive protocols in terms of visitation. And if work needs to be done, then now's the time to work on it. The literature tells us that good communication is one of the most important components of your responsive protocol. Not only what information is provided, but how it's provided. So that might be the accessibility of that information. It might be team huddles right on the unit or on the department. It might be email blasts. Making sure that that information is the important information that people need to receive in a timely manner, and that it's received in a way that's actually accessible for really busy people. And we also look at how information is delivered to patients and family in the community as well. And knowing that that information needs to be in real time because things change so quickly during the pandemic. In the article that I'm sharing with you here today, we talk about a stepwise approach to decision making, because healthcare providers always say, well, we don't have the time to bring everybody to the table and bring all the information. So really trying to get organizations and decision makers to think about what phase, what stage of the pandemic their area, their region is experiencing right now, and making the critical decisions for that moment. So really walking them through some of the planning that needs to happen, not only where we are right now, but what are we going to do if we move into the next stage? Really considering all the factors at hand. And maybe we didn't know how to do that very well during the pandemic, but we need to take the time to think about what we did well, what we didn't do well, and make a plan for the next time this happens. Because something's going to happen again and we need to be ready. We need to have learned those lessons. The article that I'm talking to you about today really looks at the value of evidence-informed guidelines. So for healthcare organizations and providers to be able to understand the rationale for the guidelines, that somebody up top just didn't say no visitors in our organization. There's evidence-based rationale behind what is happening. And again, that ongoing dialogue to be able to be responsive to changing situations. Really encouraging organizations to be not only responsive, but also flexible. So flexible to feedback from healthcare providers and also patients and families about what's working and what isn't working. And keeping in mind our commitments to uphold values and principles such as family-centered care. You can't just throw it to the wayside and say, well, this is in the name of safety. You really have to look at the rationale behind that. And what I've been doing kind of I hope we're in the wake of the COVID-19 pandemic, but we may not be. So when I work with organizations, I always encourage them, really look at your policies and procedures and ask yourself, are we able to uphold the mission, vision, and values of this organization with what we've put into place? And if the answer is no, then it's an important place to look. We also need to look at ways that we are accountable to patients and families. So how do we help them to understand why those protocols are in place? And it does really need to come back to the evidence. That is the expectation in today's healthcare. And a mechanism for appeal or reassessment over time as goals of care change. So this is a really important component that, again, takes time and energy, but it's an important part of ethical practice and being transparent and having that rationale in place so that we can be held accountable for the protocols and the decisions that are made. And in the article, my colleagues and I talk about the reason behind this is really following the ethical principle of proportionality. So weighing the risks versus the benefits. And when we have to compromise our standards, and if one of our standards is family-centered care, if we have to compromise that, if we have to say, you know what, we're not going to be able to fully embrace family-centered care the way that we have prior to the pandemic, how do we weigh that against optimizing benefits? So how are we making sense of that piece, and how are we communicating it back to our stakeholders? And we really need to ask ourselves the question as healthcare providers, as leaders, as organizations, are we doing more harm that is needed in the name of safety? And really the criteria for each step along the way as we think about a stepwise approach and really bringing in the context of the decision-making that we're participating in is asking ourselves, are we being fair? Are we being transparent? And are we building capacity for consistent decision-making that has rationale that is clearly from the evidence? So let me give you a really great example of somebody that did it well and did it right. This is from my colleague Laura's organization in Seattle at Virginia Mason Medical Center. During the height of the pandemic, they put into place a new role of a support companion. So this was an RN, a number of RNs who were designated in this new support companion role. And the reason for that was to guide patients and families, patients with COVID-19 through the visitation process at end of life. So this RN or a number of RNs were designated to meet families at the door of the organization, explain to them the process of donning and doffing PPE, walk them through the end of life process, bring them to the bedside, stay with them, and then bring them to the door of the organization again. And the rationale was not only to support patients and families, but to support the frontline staff who were saying, look we are overloaded here. People are dying alone, and we want to support people to have their family members at end of life. So they were very responsive. They listened to that need on the level of a number of stakeholders, and they did it really well. They were very proud of the fact that they were able to support a number of good deaths, and they wrote about it. They talked about it in radio interviews, and that's how my colleague Nico and I first connected with Laura to do this article. But of note, I think it's important to pay attention to the fact that this organization had the availability of both PPE and RN staff to pull this off and to be able to do this. And certainly I recognize that not every organization has those extra pieces to be able to draw on. However, I think it's important to highlight examples of what can be done. And then your organization can look at that and work with the variables that are specific to your organization. So drawing on history to inform our future next steps, when we know better, we do better. I want to draw your attention to the fact that there's some great literature that came out of SARS and H1N1, and now we're seeing it come out of the COVID-19 pandemic that told us what the hard lessons learned were, told us what we should have done, and asked us to make positive changes for the future. But more times than not, none of those recommendations were heeded. And so we moved into the COVID-19 pandemic, facing a situation that we thought we'd never been there before. But there are many recommendations that we can look back on that absolutely should have been fulfilled. And as we move forward, there's a lot of pieces of context that have changed even since April 2021, when this article was actually published. So we have now rapid antigen testing, total game changer when we think that people were waiting days and weeks to get their test results. We have vaccine passports. So how does it make a difference if visitors are fully vaccinated? Patients may be fully vaccinated. We're also going to be looking into, in future, I know I have this on my radar, but I'm sure other researchers will do this as well, a data analysis about visitors and their contributions or their lack of contribution to the spread of infection in hospitals and various care settings. So we have the opportunity to actually look back and find out, were visitors the source of the spread of infection that we had all worried about and that we had made decisions about in the name of safety. And we also can look at opportunities for infection control, occupational and health and safety department, and public health alliances that perhaps weren't as strong as they should have been. So coming out of the pandemic, we can recognize the value of these sometimes undervalued resources and continue to work closely with them. And as I mentioned, this article talks about a stepwise approach. So we actually talk about 4 different levels that organizations might consider their decision-making strategies in. We talk about level 1 as a conventional level where there's a pending surge, level 2, which is a contingency level where there's a mild surge, level 3, which is a moderate surge, and level 4, which is a crisis type of situation. And obviously your decision-making and your time for making decisions is going to change significantly as you move through the levels. And there's all kinds of ways that we've talked about leveling and decision-making throughout the pandemic. We've seen color coding, we've seen particular names for certain levels of crisis. And so I think it's really important, as like I said, we move hopefully out of COVID-19 and the pandemic, that we pay attention to the things that we did right and the things that we need to do better in the future. So with these things being said, I wanted to share with you the fact that I started working on this article from very much an outsider perspective. So I'm an academic at a university. I'm not at the bedside providing healthcare, and I was hearing all of these stories. I connected with my colleagues, 1 in Canada and 2 in the United States, who were at the bedside and were experiencing this firsthand. Once this article was published, I had the opportunity to live this experience. So this is a picture of my father-in-law. I called him Dennis. He called me Christina because he couldn't pronounce Kristen. And he was a very proud and generally healthy man for all of his life. My family were very blessed because when he went into hospital during the pandemic, he went in at a time when our local hospitals had taken the time to thoughtfully adapt their protocols for visitation, particularly for patients at end of life. And as a result, a large Italian family was able to strategically visit this man, not all at once like we used to do, but strategically. He did not speak English very well. He was hard of hearing. He was visually impaired, and he had only a few weeks to live. And we were able to comfort him, reassure him in ways that healthcare providers would never be able to. And we were able to process our own grief and say meaningful goodbyes. So he died a very peaceful death. The family had few regrets and only good memories of the quality care that he received. And why? Because we were there. We saw it. We knew that it was a good death for him. And I can't even imagine how it would have been if we couldn't have been there. Not only what his experience would have been, but how family would have imagined his experience. Further, we were able to gather as a family for his funeral and able to obtain closure to the experience of losing a very dear and beloved member of our family. So after working on this article for over a year, publishing it, and then speaking publicly about it, I did a number of radio interviews. There's a very good blog on TVO. There's some interviews that were done in the States, and I've actually shared the links to all of those within the presentation if you're interested in hearing them. I had the opportunity of living this out in real time with my father-in-law. And so I'm here to tell you that family-centered care matters. In fact, it's essential. It cannot and it should not be sidelined or undervalued for any reason. It's good for patients, it's good for families, it's good for healthcare providers, for organizations, and for our healthcare systems at large. And it is part of a compassionate response that is always our ethical duty in healthcare. So with that, I want to share with you just a few resources, and certainly there's some excellent reference lists within these resources that you can unpack for further information and new avenues to explore. These are some examples of compassionate practices and policies that really allow for people to live out their values, to recognize the value of relationships, and to achieve a synergy that could not be present if visitors are excluded from the bedside. So my article is there for you, as well as 2 other very comprehensive resources. So with that, I would like to invite any questions or comments that you might have. Thank you.
Thank you very much for that wonderful presentation, Kristen. So as Kristen said, we'll turn it over to you as our attendees. If you have any questions, you should be able to unmute yourselves, or you can pop them into the chat box if you have any comments or questions.
Hi, I have a question.
Let's go ahead, please.
I'm wondering about the effect on the grieving process of family members who lost loved ones during absolute visitor restrictions, knowing that their family member, their person died alone. Does that lead to more complex grief, in your opinion?
Yeah, that's a really great question. I would say yes. Do we have the data for that yet? Probably not, but I'm sure there's data from other situations where family members were not able to be there. I think there's a number of factors there. Some of it is just the actual fact that somebody has died without you being there to be with your person, as you've said. And the other piece is what we imagine in our minds, right? The guilt that we should have been there, that we weren't able to, and imagining what that person might have gone through, whether or not that was their true experience or not.
Right.
And I think you're absolutely right. I think we are going to see a lot of difficulties around this from a mental health perspective, and counselors perhaps helping people to work through this very unique type of grief on a level that we've not seen before. I think also with the grieving process and the pandemic is the lack of the ability to hold a funeral. So some people were not able to have the funeral at all. Sometimes people had to have reduced funerals. So picking and choosing who can come, that can cause issues within itself. And then the last thing I just want to mention is also thinking about the healthcare providers' grieving process, that healthcare providers were also very much impacted, and sometimes really stretching themselves to try to be that person at the bedside so that somebody didn't die alone. So very complex issues, and I think you're absolutely right. We are going to see an impact in the grieving process. Thank you.
Thank you. It will be illustrative of the harm that the pandemic has caused, even for people that didn't get the virus.
Yes. Yeah.
So thank you for that.
Thank you.
Thank you, Kristen. Oh, sorry. Go ahead.
Sorry. Thank you, Kristen, for such a wonderful, insightful presentation. and bringing up so many issues and, focusing back on family-centered care and how important it is. And sometimes we forget the importance of it. I love the way you bring up issues about, well, we need to think about how does that congruent with the organizational policies. And, it makes me think about then not only for the patients themselves, but for the nurses and the caring process when they don't have the family or limited family members there. And you're talking about further research there. It'll be interesting to see the outcome of COVID and if we can even strengthen some policies to improve family-centered care. And I wonder if you have any thoughts about where that might go in the future.
In terms of policies that are more supportive of family-centered
Yeah.
care? Yeah. Well, I think that the opportunity, and I'm always strengths-based, right? The opportunity of COVID, if we're willing to learn from it, if we're willing to draw on the data of patient and family experiences and have that commitment to this will never happen again. We will never let patient family centered care fall to the wayside, or we will look at doing it only in limited circumstances, but we will ensure that we have rationale, that we work with the evidence, that we recognize that a contingency plan is just that, for time limited. We don't leave something like that in place, that we have mechanisms for appeal. I mean, so many times we heard stories within the media where people were just told, no visitation, at no point, closed. There's no one you can talk to. And there was no opportunity for discussion if perhaps a family member became in a situation where they were at end of life. And very often, by the time that somebody was able to find the right person to talk to, that person had already passed away. And I had heard a story, really heartbreaking story of a family member, and this was not local, but a family member being taken away from the lobby of the hospital by police. And he only wanted to be at the bedside of his mother, and she died. She died, and he was in police custody. So, I think a commitment to, again, those organization mission, vision, and values, and learning from the mistakes, maybe not just us, but others have made as well during the pandemic, will go a long way.
Thank you.
Thank you. Go ahead, Kevin.
Thanks, Kristen. I do very much appreciate the the bringing together of a lot of this research. I think I will speak, I guess, sort of on behalf of the people who've been working hard at Thunder Bay Regional to improve access along the way and advocate. I hope when you refer to your local hospital, it was it was this one, and that's I'm glad that hopefully served you and your family well. I think where we're struggling presently is actually what you identified, which is that the current policy has not been changed now for a number of months, despite obvious, ground shifting changes in what in the context in which we're operating. And to be honest, when we brought it forward, it has been a bit of a struggle to get people to recognize the importance of this issue. I think it is going to be viewed, and I'm very heartened by that. I wondered if you had and this maybe is an unfair question, but a simple kind of recognizing your article is wonderful but long. Is there some kind of simple tool I can give to an administrator that's going to help them, tick the boxes, so to speak, as we're kind of working through it?
Yeah, I would say the two additional resources that I have listed on the slide are the most comprehensive that I've seen so far. And, in combination with my article, have some very practical approaches, which I feel like that's the most important component. Like, probably no one here or no one in your organization would say family-centered care isn't important, but is it a priority? That's where it gets sticky. And then the other thing is, if it is a priority, what can we do about it? What are some simple things that we can put into place, or who can we get working on it? And the other piece, I think, too, is, what's the evidence around it for backing up our decisions? So those three resources, I think, will definitely get you started for that.
Thanks. Yeah, it's unfortunately, we've created a system where if families, at the moment, where if families are willing to make noise and advocate, they will be allowed to visit. But some families are very compliant, right, in our healthcare language, and they will simply accept that, okay, four is how many we can have. Well, okay, we'll have to choose the four, and which child is not going to be able to come. So
Yes.
yeah, hoping we can continue to keep keep this evolving as we go, to keep it, as you said, proportional. So thank you for your
Yes.
work on it. I appreciate it.
Yes, thank you. And please feel free to reach
Personal.
out to me. I'm happy to help. Like I said, I'm deeply committed to this. And you raised a really interesting point that you want your policies to be fair.
For your
You don't want a policy that's not working, and the only time that people get what they need is when they bang on the door of the CEO or blow something up on social media. So yeah, it's definitely a very important piece to pay attention to. So thank you.
Kathy has a question.
Hi, Kristen. Thank you for the great presentation. It was super to hear about your work on this. And I'm interested in hearing your thoughts. And again, looking into the future, but paying attention to what's going on right now, for example, in southern Manitoba with the mass exodus, if we can call this, of healthcare providers, particularly in the area of long-term care. And so now the discourse is changing so that it's not about people not being allowed into long-term care. It's now, please come and do all the essential care that we no longer
Right.
have paid staff to do. I'm paraphrasing, we know this.
Yeah.
So I'm wondering, how do organizations go about in your recommendations to best repair the relationships that have been so harshly damaged and the increase of mistrust between people, and how do they manage to go about and ask and incorporate them again in these, continuing times of COVID?
Mm-hmm. That's an excellent question. Thank you, Kathy. I think this has been a long time coming. I don't think this is a COVID thing. It's not a pandemic thing. Moral distress in healthcare has been in the academic literature for over 40 years. And that's why I see this really as an opportunity. So just like Kevin was mentioning that, certain things aren't a priority. We know they're important. Well, healthcare organizations can no longer ignore the fact that moral distress is happening, that their environments are environments of moral hazard. And so I've had this question posed to me over the last couple of years by organizations, and I've said to them, you need to sit down with your frontline staff who are still there. You need to be willing to hear the things that you don't want to hear, and just, don't invite the conversation and say, yeah, we're going to do something about it and not do anything about it. Really commit to making the changes that need to happen, recognizing that, if you ask for that feedback, you hold a responsibility to do something about it. And also to outline some reasonable expectations in terms of, we're not going to fix this tomorrow. We're going to need to work together long term. And that's also going to require putting some money into it. There needs to be some investment in the frontline staff that remains, and to changing that overall, whether it's that ethical climate, whether it's reducing that moral hazard. And I think, across the board, there's going to be some common things that need to change in healthcare, but I also think there's some sector specific issues. Like I think the issues in long-term care different perhaps from an acute care setting. And within acute care, you may see different issues for that team in emerge than you might see in the OR or, in that inpatient surgical unit. For me, it always comes back to building relationships. And I've really encouraged organizations that, this is your catalyst point, COVID-19, that we can say that change is needed. And if we ignore this opportunity, we're going to see exactly what you've described. Healthcare providers getting up and walking out and perhaps not coming back. And we're not going to see a lot of new grads coming into those positions, because we're even seeing new grads leave. And so the reason why I've been part of some of these conversations is because a lot of times organizations will turn to a university and say, geez, you need to get more nursing students out the door. And the conversation really is about, how can you keep them once they get there, and how can we work together towards a better environment. And part of that better environment is also thinking about what patients and families' needs are. And it's not always about reaching out and doing a focus group. We're all potentially a patient. We are all part of families. And so some of that is just thinking about the decisions in the context of what would happen if I had to live this. And I've often wondered for some of these protocols, I can understand why they were made in the name of safety, but I have to wonder if anybody sat back and thought, what if that was my partner? What if that was my mother or father? What if that was my baby all alone, or I had to choose whether me or my partner could go and be there in that moment? So these are hard decisions and we need to work on them together.
Thank you again, Kristen. Not seeing any other hands raised at the moment. There were a couple of comments that came through in the chat. Catherine Smith, I'm so happy to hear this timely presentation. The absolute visitor restrictions will have long-lasting negative impacts on thousands of people who have had a loved one in hospital or any healthcare institution. She says, bravo for the research and published article. And I did have a question that came through to me on a private chat, but I think you definitely just answered that. They were asking if you think many nurses have left the profession due to COVID-19 or the mental stress that it's been putting on their lives. And if so, how are they coping? Pretty much covered that off. Few minutes left. Any final questions or thoughts for Kristen?
Maybe I'll close off. I just want to say thank you to all of you for being here today, and certainly want to encourage that you take a moment for yourself. If something that I've said has been impactful to you in terms of what you've already been throughout the pandemic. And again, I would encourage, it's not just my job to move it forward, or you within your own organization. Use these resources, use the tools to say, here's the evidence. What are we doing about this? How are we supporting each other to uphold our values and to deliver the kind of care that, if we were the patient in that bed, we would be happy to receive. So it's really all of our job. And thank you for your time today. And I would encourage you to reach out to me at any time with any questions or comments. We'll continue to work together. Thanks, everyone.
So Kristen, just on behalf of the Center for Education and Research on Aging and Health, I want to thank you once again for taking the time to speak at our series today. Thank you for sharing your own story as well, and really for validating and drawing out these experiences of moral distress, injury, moral hazard. That's a new one for me. I never thought of that one related to the environment, so that's interesting. And also bringing back once again to the importance of family-centered care that it comes down to. So we very much appreciate your time. That was an excellent presentation. And I was just going to quickly let people know about our next session in our Sarah Speaker series, which will be on Thursday, November 25th. And it will cover telehealth for wound self-management, improving access and outcomes, chronic wounds for older adults in Northwestern Ontario, with Dr. Edie Costa as our speaker that day. So you'll be able to register for that soon. So thank you all once again for joining us, and have a great afternoon, everybody.
Thank you. Take care, everyone.